Thank you for the invitation from the GIS and thanks for true hospitality. I have عتب بسيط. Vascular is where we start and where we finish. So it should be the first thing in the morning. That's where it make you and it will break you.
Wallah, if you don't make it now, you will go away.
So in order to make it a bit more tolerable at this hour, I decided to infuse some of, I shouldn't say my complication. It was a ghost who did all this complication. And I will try to infuse some of the data that, in my view, changed my practice over the years. So nothing to disclose. I just want to say, again, this is, I think, after the Matrix trial, access choice is not just about convenience, it's about survival. I'm not going to dwell about the coronary part because we all are trying to be radialist, I should say. And it took us a while. But in general, they have strong evidence to suggest that from this meta-analysis, all randomized trial, to suggest that radial approach should be the default in all comers. But we have also, for people who are debating this evidence, some of us will say, well, if I am an excellent femoral operator and I do not get any bleeding, probably this mortality benefit might not show, and I will take that argument. But for the coronary side, I think radial is or should be the default strategy. But how are we doing with the radial currently? This is data from the STS, and basically looking till 2024, how much is the radial uptake? And you could clearly say that there are 30% of the cases that is not done radially. And when you look at the data or the outcomes that has been attributed to switching to a radial approach, clearly all death, major complication, major vascular complication has significant reduction with the radial, with the exception of the old nuisance stroke. Clearly there has been a clear signal favoring femoral over radial. So I'm going to switch quickly to I think the main theme of the talk, which is the large bore axis. And we have been using this definition all along, but it seems that any time when we are using any sheath more than or equal to 8 French, we should think about complication. That's the first tip that we should tell ourselves. But in reality, when we are talking about large bore axis, it is mostly between 12 to 22 for EVAR, 13 to 25 in most of the mechanical support device, and for most of the current labeled TAVR device, 14 to 18 French. But we came very far. This is literally a case in 2009. I remember this because I used it in a presentation when I got recruited to my first center. And I just said sorry, it's not. It's just becoming bigger. Okay. I'm just trying to show you that truly the 25 French is as big as the TE. We came way. So now this is the next thing, again, another case, and I'm sure some of us got this. When we used to do large bore axis without CT and we rely on the femoral angiogram, we got stuck sheath, and basically, I remember cases where we have to abandon the case because there is the sheath does not go further to deliver the valve. How did we get better? Clearly with the CT. But for any individual operator who deal with axis in general, not necessarily large bore axis, the current trick is to realize that there are some old predictor hasn't changed over time, proven by data. Vessel calcification, sheath vessel size ratio, being a female still, and the learning curve. So vascular complication in all trials that involve large bore axis, specifically TAVR, if you develop a vascular complication, you will have higher mortality than if you did not develop vascular complication. Now, the definition got refined later on, and clearly minor vascular complication did not necessarily associate with mortality, but all VARC definition for major vascular complication has been clearly associated with poor outcome. How did we get better? One is devices. For sure, if you notice, the fringe size in all devices has came down in both the balloon expandable and in the self-expandable. We are now for certain platform asking for 5 to 5.5, and maximum vessel diameter of 8 can ensure the delivery of most available platform. But I would just, again, this is a history lesson. If you look at the source registry from the initial outcome. We are talking about 1 in 5 patients who goes through a TAVI will have a major vascular complication, which is a significant thing. This ratio, I still use it to this day, although I break the rule from time to time because of the addition of shock wave, but it gives me a hint of whether or not we are going through a smooth case or not. A vessel to a sheath ratio that is more than 1.5, again, has stood the challenge over multiple analysis to tell you as an operator that you are taking a risk in terms of vascular complication. 30 versus 6.9% if you have a sheath to a vessel ratio more than 1.05. Now, as we looked in the literature, there's clearly also the addition of other vessels, specifically the iliofemoral vessel, and you could see also if you have such a ratio, you will likely have a smooth sailing. Now we hear about calcification and tortuosity. You hear it in all the report. And honestly, till this day, I hear about tortuosity, I appreciate tortuosity, but which tortuosity that make me really concerned if there is associated calcification, because most of the time those loop does not tend to straighten. Another way, if I like to communicate with somebody who is reporting a CT scan, they say extensive calcification. That not necessarily help me. What I need to hear is what is the degree of calcification at my puncture site, because that will determine what is my risk of vascular complication related to access. And there's a clear definition that everybody can look at it in the literature. But if you do or you don't have vascular complication, that will clearly define the outcome of your procedure. Vascular complication clearly associated with poor outcome. So I'm gonna break the dry part and I'm just gonna say one ghost did this case. This is an non-TAVI access site and the label was secure vascular access achieved by perclose. I'm going to just run it and I'm going to show you what happened with the patient 2 hours later. Hypotensive, most of the time, we used to send them for CT scan, but if sometimes we know that the patient left the cath lab and I don't feel relaxed about it, the first option is, no, you know what, bring him to the cath lab. We'll bring the IR guys if needed. But as you can see, there is occlusion at the vascular site caused by the perclose, and I remind you, this is not the TAVI access site, and there is a perforation. So you may ask, what caused the perforation? Again, most likely, it is the hook of the perclose, or as we enter with the perclose in the wire, we can definitely shear the wall of the artery. Now, mistake number 1, we decided to go with the old way of dealing with this. Let's do a balloon sealing. We did. And I'm just going to let the movie play. And I just show of hand how many people will leave this. So I did the same thing. I'm glad. I did not do that, so that's why I'm in a continuous learning process till this day. So 2 hours later, the patient comes, and the one in the right is the one before the intervention. So the one in the left is the one after my intervention. The one in the right is 2 hours later. And at that time, we called an expert to say, well, balloon from vascular perspective doesn't work with the time. Let's just put a cover stent. So patient survived. What did I learn from this? I remember Hussam early in the morning said something about what do we learn from our complication. I never look at my complication the first 24 hours. An old mentor told me that. Never look at it in the first 24 hours. Always look at it in 2 to 3 days. You are more relaxed and you can critique yourself. So what I learned from him, I'm a slow learner, and whenever I get used to something, I stick to it. From the time that I learned TAVI, I stuck to both axis in the groin. Why do I need to change? I will come to that later, but in case you need to stent the femoral, we have now an accumulated data to show that don't shy away from the stenting, because I used to shy away. I don't want to put a stent in that area because, it's across the joint line. There is accumulated evidence to say definitely it is safe up to 1 year, but keep in mind when we lower the bar for patients who are at the low risk, who are very active, it's a different story. This data came from people who are in their 80s, doesn't do exercise, but when you are dealing with a younger patient, maybe it's a different story. So time to change. Probably I did not do this change completely, but I'm slowly getting there. Use the radial axis, fight over it with anesthesia, although it has its issue, especially in older population when you have an ascending aortic tortuosity and you need to put your pigtail in the non-coronary cusp for a deployment, it has its own issue. Lift is more important, more, I would say, ergonomic. The problem with the lift is you are really going to kill your back throughout the case. But the second most important thing about the radial, if you're going to dive into it, make sure you have equipment to bail you out that has the length to go all the way to the femoral. Otherwise, you're going to be in square one where you're going to have restick the femoral with an ACT more than 300. The perfect case, these are the cases that you look at the CT scan and say, nothing will happen, let's go and do it. Big arteries, zero calcification. And you get a successful procedure, ready to go. Let's take the perclose, and here is what you see in the femoral artery. So how many people will leave this? How many people will do anything about this? Anybody will leave this and say, I have some flow? You got to do something about it. So in this case, probably I did 2 perclose. And again, this is something that you learn with time. You need to step away from what you have been taught. 8 millimeter arteries behave differently than a 6 millimeter artery. So this is clearly caused partly by dissection and cinching of the 2 perclose. So what I ended doing is basically I did what I used to do, dilated. And then we had an excellent flow afterwards. And this one, I said, well, successful result achieved. But again, we looked at this and we started to change our practice. Luckily, same time, and this is again around the time where I have to discuss with you the access TAVI, 2 closing, 2 perclose versus 1 perclose and an angioseal. Clearly, likely we have to change to 1 perclose, and I say in my own practice, I do not even use the second angioseal routine, except if there is really a significant oozing. But this clearly been a changing for me in terms of switching from 2 perclose versus 1 perclose with good result. But even if you want to rely on the data is very clear. 1 perclose with an angioseal added is better than 2 ProGlide. Now, protamine versus no protamine, we used to fight over this all the time. Do I give protamine or do I don't give protamine? I personally was very happy when I saw this trial because I was a strong proponent of protamine, but I did had my share complication with occluded artery when I gave protamine. So our routine has been all the time to try to give half the dose of the protamine and to avoid complete reversal. But clearly, if you do use protamine, your time to hemostasis is going to be short and you have less hematoma, no hard outcome. Now, the old question / new question, MANTA versus suture-based. I think I do believe that there are people who are strong and probably more skillful in MANTA, but probably the evidence does not support the use of MANTA currently as the procedure of choice for closure. As you can see from the data, the MANTA has been associated with more intervention, more call for vascular surgeon. Now this has been also, I did not bring Muhammad Abdul Wahid trial, but also this trial was negative. Now this is something that I did not dive into, but I think it's something worth for center who honestly try to minimize the instrumentation. This data from Kabadia from Cleveland Clinic, where they basically use single axis for their alternative axis. One thing about this data, it's single center. There is no follow-up to indicate what happened to the single axis, but clearly in this trial, they showed their adoption rate over time, and basically their vascular complication rate has been reduced with the adoption of single ipsilateral. And the way to do it, even without ultrasound, they necessarily do the ultrasound for the small axis. They use the ultrasound for the larger axis, and they go 2 centimeters below the large axis, and they do just the puncture. And usually it's a 6 French with a 5 French pigtail. Has been shown to reduce complication. Probably some of you already has been using it. So I'm going to close with this to keep me always humble, and I'll tell you why. For those of us who trained around 2006 to 2009, We used to do 8 femoral puncture. We are invisible, no ultrasound, with the torquer or whatever you want to fluoro with, and go with the anatomical landmark. And just 1 minute. And basically what I learned is we, with time, thanks God for the large bore axis, we become sloppy in the femoral axis with time. Because if you look at your list nowadays, probably you will do 8 or 6 in the busy cath lab. You will do it 6 radial and 1 femoral. And I notice in those cases, these are the cases that I go into it, I don't feel comfortable anymore like I used to be as a fellow, because, you know, you stick 8 groin, then you have no issues. So this is a case where I tell you and I remind everybody, ultrasound versus no ultrasound. Most of the time you will not get into trouble, but this case, morbidly obese, and I will show you the data behind it, and what trouble we get into, and I will just show you. Where is the trouble here? It is the neck in the inferior epigastric artery. Why? Fishing, most likely fishing. Got fed up with, I'm locating the pulse. The best action was, let me grab the ultrasound, and rather than guessing, I want to go and find the artery by visualization. This is a nuisance because you cannot stand across it. It will have a retrograde flow and it will continue to bleed. The only way to fix it is by coiling. Well, do I have an experience with coiling in peripheral artery? I learned after this case thanks to my IR colleagues, but basically they came to the rescue and they fixed it. So I'm going to skip through this for the time, but my take-home message is planning CT is not just to say the artery is good caliber. Calcification has to be part of the picture, whether there is tortuosity or not. It is part of the consenting, especially if you have a high-risk axis. And all cath lab is equipped. It doesn't hurt if you review your equipment from time to time because you do not use them very often. Thank you.